All right, let's talk about using ketamine to treat difficult chronic pain conditions. I'm going to try to keep this short. I have a major grant due later this week. The grant is all written. Now I just have to go over everything and make sure there's no embarrassing mistakes hiding somewhere. But anyway, I can take a little bit of time to talk about ketamine treatment for chronic diseases. Now, ketamine is a dissociative anesthetic. It's an NMDA receptor antagonist, and it can keep pain messages from reaching the brain. It has some interesting anti-inflammatory effects in the brain that are kind of more newly discovered, and it's been observed to increase neuroplasticity to allow restructuring of brain pathways. It's a fascinating compound, but the effects of ketamine on brain processing are quite complex and would take a much longer video to cover. So maybe I'll go through all those really neat mechanisms of ketamine and what we think it's doing to the brain and how that may be helpful. I'll do that in another video. For now, I want to introduce a new paper from the Cleveland Clinic, and it was led by the primary author, Dr. Tunka, and it is called Standardized Ketamine Infusion Protocol for Chronic Refractory Pain, a retrospective study of preliminary effectiveness and treatment completion. Now, this is an open access paper, so you should be able to get it at the link I put below. And this is a retrospective study where they look at the medical records of 1,034 chronic pain patients who were given ketamine at the Cleveland Clinic. So this is not a clinical trial. It's an analysis of people who were given this treatment by the clinic. Now, they used a standardized low-dose ketamine protocol with zero point 0.5 milligrams per kilogram ketamine and an intravenous infusion of 40 minutes. And this would be around 40 milligrams or so IV ketamine for a typical US female. So a fairly low dose and a pretty gentle infusion rate. And they did this infusion protocol for 5 consecutive days. So you get 5 doses of the IV ketamine on 5 consecutive days. So people with chronic pain were given this protocol. These individuals failed conventional pain therapies. So normal treatments did not work. So they still had substantial pain that had to be treated. Now, the largest group they seemed to be fibromyalgia type pain, but there was also a lot of neuropathic pain syndromes in this group of 1,000 plus people. And there were some more specific pain syndromes like headaches and facial pain. So there was a lot of different types of chronic pain included in this study. So they bring the people in. Yeah, the patients sit in the infusion chairs. They're monitored by nurses in case they have side effects like nausea, and they have all their vitals monitored, making sure their breath rate and their blood oxygen are good. And then they're watched for 30 minutes after the infusion, and they're being watched for perceptual or behavioral disturbances, and also to make sure that the patients don't try to drive themselves home. Really, you should take 24 hours off of driving to be safe. I'm not going to talk about it today, but you probably know that ketamine can cause some strange hallucinations depending on the dose and the person. And these are expected effects of the acute infusion period. Anyway, it's not the best time to drive. So, how did they measure if people got better? Well, they looked at several outcomes before treatment, right after the fifth treatment. So they did it before treatment, right after the fifth treatment, and then at 3 months and 6 months. These were follow ups. So 3 months and 6 months after they had completed the treatment. And so they're looking at the efficacy of ketamine in a real world setting. And they're also looking at the treatment durability. So does it work for a long time? When do the effects start to go away? Now, they looked at a lot of different things. They looked at pain intensity. They looked at pain interference with activities. They looked at depressed mood, anxiety, pain catastrophizing, which are maladaptive emotional and cognitive associations with the pain. They looked at fatigue, sleep disturbances, and a few other domains. And all of these things were measured with self-report tools, and they identified a person as being a treatment responder if they had their score reduced by at least 5 points. So if their baseline depression scale score was 12, then a reduction to 7 would be a treatment responder. And that's the case for all the scales except for anxiety, I think, which requires 4 points instead of 5. And it's because of particular properties of the scale. You can read the details in the paper. They explain why that one scale has 4 instead of 5 point change. It's not important for the introduction to this paper. Okay, so what happened? Well, first, the treatment seemed to go well from a safety and tolerability standpoint. There were no serious adverse events recorded. The side effects that they listed were what you would expect. And really importantly, 86% of the participants got through the entire 5-day protocol. And that's a very good retention rate, especially considering that it required coming into the clinic and finding a ride there and back on 5 consecutive days. And now, if you're interested in learning more about side effects and things like that, that information is available in a supplemental file that you can access. Okay, and then the big question, how well did it work? Well, they did some mixed model statistics, and all the measures were significantly improved at the end of the 5 days. And you can find that on page 6 if you download the paper. At 3 months, everything was still significantly improved except for ketamine's benefits on sleep disturbances. That was no longer significant. And then at 6 months, some things started to drop out of significance, though there were still several benefits maintained at 6 months. So the results, as I'm reading them, are indicating that a booster session may be helpful somewhere between 4 and 6 months, which is in line with how ketamine works in other conditions like major depression. So that's not really surprising. Now, here's a figure from the paper that shows what percentage of patients have a clinically meaningful response in each of the outcomes after treatment, at 3 months, and at 6 months. So, for example, you can see that around 20% of patients had a meaningful reduction of their depressed mood, and that benefit was maintained at 3 and 6 months, which is good. And then over 30% had a meaningful reduction of their fatigue, which was maintained at 3 months, but we started to lose that effect on fatigue at around 6 months. Now, it's tempting to use this chart to try to figure out what symptoms respond best to ketamine treatment, but I caution against doing that because these scales have different possible ranges and they have different baseline levels. And so the 5 point criterion may be more fitting for some scales than others. As a quick example, this really big bar you see that shows that 45% of people had a meaningful reduction of pain catastrophizing, which means they were less afraid that the pain was going to ruin their life and that they would never improve. And it's possible that ketamine had unique actions on pain catastrophizing. But I also have to note that this scale has a baseline of 25, while depression, for example, has a baseline of about 12. And so a 5 point change in catastrophizing is only a 20% improvement, but a 5 point change in depression is a 42% reduction. That's twice as big. So I hope that makes sense. But basically, I'm saying I suspect that if we better controlled for the different ranges of the scales, we would probably see this really big bar for pain catastrophizing come down closer to the other scores. That's just my prediction looking at the data. It's a testable hypothesis. The main point is that teasing out the differences between all these scales, it's probably not what's important to patients. The general gist of this figure, as I'm reading it, is ultimately either 1 in 5 or 1 in 4 chronic pain patients will get meaningful benefits from this treatment. I don't know which one it is, but either one of those would be good. A 1 in 5 response rate definitely would indicate a useful clinical tool. So what do I think? First of all, it's a very good paper. It's easy to read. The main strong points are the large sample size and the standardized treatment protocol. The main limitation we've already mentioned, it's not a randomized control trial. It's not intended to be, but that means the paper can't tell us how much this treatment, the ketamine, works better than placebo. And that's important in all cases, but it's also especially important in this case because this clinic uses a biopsychosocial model and they spend a lot of time and a lot of effort establishing good clinician patient rapport. And so some of the benefits that we see might be due to that constructive relationship, kind of like a psychotherapeutic relationship. And so we can't attribute the benefits that we see specifically to the ketamine without having placebo-controlled trial. But on the positive side, this does measure people in a real-world clinical setting, and so it gives us a good idea of what to expect. The response rate was probably not as big as the research team was predicting, but I think the response rate is quite solid, especially given that these were refractory pain cases where other pain treatments didn't work. And so these are the most difficult cases. And it's nice to see that some of these individuals who didn't respond to anything else are experiencing something that was able to benefit them. And I think, as I mentioned before, I think the durability of the response, how long it lasts over time, looks good. And it just is, it's a more feasible protocol to follow. If you don't have to be treated constantly, you can wait for months between treatments. Now, some other negatives, nothing to do with the study, but it has to be mentioned that ketamine is a serious drug with profound effects on your experience, depending on the dosage. It's true that many people will get euphoria, for example, from ketamine because the drug blocks the NMDA receptors that are on the dopamine inhibitory neurons. And so it releases the brakes on dopamine and it causes a surge of the neurotransmitter dopamine, which can cause euphoria after administration of ketamine. And some people are more susceptible than others to that effect. For some people, it's not going to be a big deal. It probably has to do with individual genetics and response to different drugs. But some people have a lot of drug liking to ketamine, and that can lead to drug abuse. And that's why this treatment is given in the clinic rather than at home. So let me make sure this point is clear. I am not aware of any medical professionals who support at home unsupervised use of ketamine for chronic conditions. And it's certainly not FDA approved to be used that way. That's for ketamine, and that also includes S-ketamine, which is available intranasally. Even the intranasal form has to be done under observation in a clinic. Now, I'm sure there's groups working on ways to use it at home, but to my knowledge, there's not a way that has been validated yet, at least in the United States. Now, of course, there are definite ways to get a hold of ketamine and use it at home, but it's just not an advisable way to use that drug right now. Of course, I totally understand that for many people, they are desperate for something that works. This drug could help. And for a lot of people, it may not be available from conventional medical venues. And so you may pursue alternative ways of getting the ketamine and trying the ketamine. There, of course, are risks with doing that. One big one would be miscalculating the dose. And then there's concern that the psychological dependency and the possible addiction can be very subtle in their development. So I think I worry that people don't know that they're becoming addicted until they have a very severe problem. And so you need a trained external observer to watch out for those things. Okay, what about things other than chronic pain? Well, we saw in the paper that it helped a number of different things, had an interesting beneficial effect on fatigue, for example, but I'm not aware of any published randomized control trials of ketamine specifically in ME/CFS or long COVID or Gulf War illness. So we don't know if ketamine is going to help those conditions, but it's a reasonable idea. So I would like to see clinical trials in those conditions. In the meantime, it's worth discussing this possibility with your primary care physician, especially if your condition has an element of chronic pain or depressed mood. We know that some people have had their lives radically transformed for the better with this drug. So it is appropriate to think about this option, especially if you've tried everything else and nothing has helped. Okay, so I hope that is some helpful information. I'm going to get back to finalizing my grant. Now, I have a bad habit of instead of typing clinical trial, I accidentally type clinical trail, and I can't have stuff like that in the grant. So I have to look over every single word and make sure this thing is perfect before I send it out. So that's what I'm doing this week, and I will be back very soon.